Hello and welcome to Seminar 4 in a series on addiction. This seminar looks at specific information on opioids, alcohol, sedatives and cannabis. This is broken up into 3 parts, A, B and C. I'd like to acknowledge Community Drug Action Team, Port Stephens for sponsoring this series, and Samaritans Foundation Recovery Point Program with whom I'm co-located. My name is David Outridge, I'm an addiction medicine specialist. But just to orientate ourselves to where we're going, these are the 5 dimensional groups of drug effect. We've dealt with in Talk 2 the stimulant group, which includes methamphetamine and cocaine. These result in an elevation of people's thoughts, feelings and energy. Opioids have an effect through from pain relief through to euphoria. They also have a degree of sedation. Bonding, which really just includes ecstasy or MDMA, is interesting, has both a stimulant and a bonding effect through the release of oxytocin. Hallucinogenic drugs distort perceptions of reality and have some attraction through a sense of enlightenment. Sedatives suppress the nervous system. This includes chemicals such as alcohol, the benzodiazepines, which include Xanax and Valium, and the old barbiturates, which are very uncommon now. Alcohol is an example of a substance that crosses groups. It also has some endorphin releasing effects, so you could say it has some opioid-like effects, that is, it makes people feel a bit euphoric as well as sedated. Cannabis covers both slight sedation and mild hallucinogenic effects. When used medicinally, it can have some anti-nausea effects and can improve pain tolerance. There are also some novel psychoactive drugs that are appearing on the streets, and these really are just newly synthesized chemicals that can cover various different groups. Some are stimulants, some have cannabinoid-like effects, but these are forever changing and hard to characterize, so they won't be covered in this talk. So we'll be looking at opioids, alcohol, sedatives and cannabis. We'll be looking at the background to these substances and why people tend to use them, their main effects on the body and particularly the problem effects, and we'll be looking at the treatment for dependence on these drugs and the risks associated with treatment. So first, the opioids. These are essentially the strong painkillers. This includes the list here: heroin, morphine, which can be pharmaceutical, oxycodone, such as OxyContin, codeine, Panadine, hydromorphone, which is Dilaudid or Genista, fentanyl, which is used in anesthetics and also in a skin patch, methadone, which is liquid or tablets, buprenorphine, which is either a strip or a small tablet, and tramadol. So why do we use opioids? Opioids mimic the effect of a group of chemicals in our brain called endorphins. Endorphins are natural painkillers that allow us to do things that are important and yet still may be painful. Dopamine is a chemical which is released when we do things that are pleasurable and is reduced when we face things that are aversive. If it wasn't for endorphins, we would be our behaviour would be driven by that pleasure-pain dynamic, and we wouldn't be able to rise above that. Endorphins allow us to rise above that, and it is enhanced by things like exercise, making music, laughter, eating, sex, and a whole bunch of other things. But mankind has discovered that the opium poppy produces a chemical which is binds to those endorphin receptors and produces pain relief. It's been known about for many thousands of years, and the Sumerians 3,000 years ago were aware of it and called it the joy plant. Since those original natural opiates were discovered, mankind has synthesized other ones which are synthetic or semi-synthetic. Oxycodone is a semi-synthetic opioid, and fentanyl, hydromorphone and tramadol. These are examples of purely synthetic opioids. How does addiction start with opioids? Opioids by nature are highly reinforcing, either through euphoria, which can occur accidentally through having a little bit more than is needed for pain relief, or by recreational experimentation. It also creates a physical dependence, which creates a withdrawal effect quite rapidly within weeks. That withdrawal in a person with chronic pain can manifest as an increase in pain. So both through the positive euphoric effects and avoiding the painful negative effects, opioids can be quite reinforcing. And there are two pathways to addiction, often through the non-medical pathway, which can be in people who use recreational drugs, or people who tend to self-treat their own emotional symptoms with chemicals. Then there's the pathway through medical use. Chronic pain patients who are exposed to long-term opioid treatment often develop addiction. In some studies, up to 20% of long-term opioid users for pain relief can develop addiction. And through acute pain, where people simply accidentally discover that the drug helps with other things, such as underlying emotional pain. The risk of addiction is increased by concurrent mental health issues, developmental issues through growing up years, such as ADHD, anxiety, trauma. A family history of addiction is also a risk factor, and a history of prior substance use is a risk factor for becoming addicted to prescription opioids. So what are the particular problems of opioids? Let's look at three categories of problems. One is too high a dose, the second is regular heavy use, and the third is addictive use. Too high a dose can happen accidentally. Too high a dose can lead to depression in people's breathing. That is, the person can have very slowed breathing and even stop breathing. They also tend to fall off to sleep, and this can lead to accidents. The suppression of breathing can also make sleep apnea occur or become worse, which is associated with other risks such as high blood pressure, stroke, heart failure, etc. But stopping breathing is clearly the most serious side effect, and in America there's an absolute epidemic of deaths from opioid overdose. Near misses can lead to prolonged low oxygen levels to the brain and brain damage. So opioids are a very risky drug from this aspect. Regular heavy use can lead to a physical tolerance of the drug, and as we mentioned before, a withdrawal syndrome in itself that can be like the opposite of euphoria. It's quite distressing and hard to cope with, despite what people say. It's an extremely difficult thing to get through from a high dose. Also, an exacerbation of pain. If someone is on opioids for pain, the withdrawal can manifest as increased pain. But opioids in themselves also reduce people's tolerance to pain. And this is a phenomenon which has been increasingly recognised and a reason why opioids shouldn't be used long-term for chronic pain. And in regular heavy use, there's also the risk of overdose just through accidental overdose. If a person has decided they want to detox from illicit drugs, then they have a period of losing their tolerance for the opioid. If they go back to using the same dose that they were using, or even half the dose they were using, there's a very high risk of an overdose after returning to drug use. But in the medical or the pharmaceutical opioid user, the risk of overdose is there through simply combining one's normal dose with another sedative, such as a sleeping tablet or alcohol. Addictive use, which occurs in up to 20% of long-term medical users, refers to a situation where people have lost control of their use, and this then leads to other major problems with their reputation, their work and family situation. Once addiction has developed, then the difficulty is that relapse, statistically, relapse is a very high reality, up to 95% per year relapse after detox. Untreated opioid addiction is a highly lethal condition long term. Over a 25-year period, half of people will die without treatment. That's 1 in 50 per year. So it's important to recognise these particular problems with opioids. It's important to distinguish addiction from medical dependence, for which a process of gradual reduction in dose can be achieved. So what does medical dependence look like as opposed to addiction? And medical dependence is often occurring when someone who's got chronic pain with opioid tolerance, that is, they've got used to a high dose of an opioid, and going without that opioid will lead to an exacerbation of pain and withdrawal symptoms. But there's often inadequate pain control despite a high dose of opiates. There's also a focus on opiates by the person. There's a belief that it's simply impossible to manage without the opiates. This has been formed by just experience of trying to reduce and the increased pain or difficulties that occur. There's often coexistent depression, anxiety, and anger or irritability in this situation. And this doesn't necessarily mean the person is addicted. It's simply that they've become very emotionally run down and have few options, apparently. There's also increasing disability and loss of function. So despite trying to achieve pain relief, the person is actually becoming less functional and doing less. There also may be some particular drug-related behaviours that point to the fact that there may be difficulty with managing the medications. So arguing with the doctor about the dose, escalation of the dose, unsanctioned escalation of the dose for increased pain, seeking opioids from other sources, shopping around to a different doctors, going to the local hospital emergency, and also treating other symptoms such as low mood with opioids. These features aren't necessarily addiction, and they can often be managed through a program of recovery and through a pain service such as the Hunter Integrated Pain Service, or through psychologist and rehabilitation. The transition to addiction from medical dependence can be a bit of a grey area, but looking at some of the features listed below, you can get a clue as to whether addiction has occurred. Under 3 headings, again, the loss of control, objective problems arising from medication use, and craving. So under loss of control, repeated efforts to cut down have failed, repeated departure from the doctor's instruction, resistance to change despite adverse effects, for example, ineffectiveness of the medication, peaks and troughs, constipation, major escalation in dose or pill tampering to make medications quicker acting, or intravenous use. Under objective problems, deterioration in work, social or family life, morally or legally compromised state, such as through stealing drugs, forgery, black market sources, illicit substances, or lying about prescription loss. And then craving for the opioid itself, which overshadows the pain issue. So how do we treat problems with opioid use? Looking at 2 aspects, one medical dependence and the other addiction. In both cases, people should have take-home naloxone, as shown in the photograph. This is a kit which has an antidote to opioids, and it can be prescribed or possibly obtained free from a pharmacy. It's used by bystanders to counteract an opioid overdose, which is evidenced by lack of breathing or infrequent breathing, noisy breathing in the presence of an unconscious person. It works very effectively and is simple to use, provided some basic instructions are given. However, in medical dependence where addiction is not present yet, then a process called deprescribing is carried out. And deprescribing involves gradual reduction in the opioid dose at a slow rate, alongside psychosocial therapy, which aims at changing the mindset from being very medication focused to being more positive, and physical therapy, which helps a person to regain function. This can be very successful and is often available through the local health district through a pain clinic. If the person is resistant to entering into this process, that may give a clue to the presence of addiction. And addiction needs to be accepted when present, because denying the presence of addiction can only put the person at greater risk and certainly make their life worse in the longer term. And the available treatment for addiction is opioid replacement therapy. Detox should not be performed unless it's a very early stage of the process of addiction, due to the risk of relapse and possible overdose, and certainly monitoring needs to be maintained if that person is going to be detoxed. In the next slide, we'll go on to look at opioid replacement therapy in a bit more detail. Opioid replacement treatment is a maintenance treatment for opioid addiction. It involves administration of a long-acting opiate which is not associated with highs or lows, and therefore eliminates craving. It also eliminates the risk of overdose because it maintains a level of tolerance to opioids. It results in a functional outcome, which is that the person ceases to be addicted to opiates. That is, the person is not craving, the person is not controlled by the drug, and the person is not showing objective signs of problems in their life. They simply get on with their life and do not think about the heroin they were using before. There are two medications available: methadone, which is a liquid, buprenorphine, which is either a film or a monthly injection. Many times this treatment is avoided because of an ideology that abstinence is morally superior to being on a medication. This ideology, unfortunately, ignores the practical facts that people do die after abstinence treatment at quite a high rate. And in contrast, people on maintenance treatment get on with their lives and can return to normal family life, normal work life, run a business, do study, and that kind of thing. This ideology, unfortunately, prevents many people from obtaining treatment through a general community attitude that is somehow promoting addiction. Addiction is the syndrome which we are treating with this, and in the same way, people who are diabetic require insulin, and without that they die. The same way people without this treatment would die. So morally, it can't be justified to deny people opioid replacement treatment. It can be available through any GP because GPs are licensed to prescribe up to 30 patients. They can do it under their own right or under the auspices of an accredited GP. An accredited GP is someone who's done a specific course which allows them to prescribe more than 30 patients. So just to really plug this this treatment as a really a life-changing treatment for people with opioid addiction, whether it be through illicit opioids or through medicinal acquired addiction. Either group respond very well, and we'll certainly thank you for commencing them on treatment. Treatment is maintained indefinitely. There is no point reducing them off the treatment prematurely. The person often needs to be on the treatment at least for 10 years in order to overcome the addiction and for it to become a distant memory. In many cases, people need to process trauma in order to allow them to come off the opioids without a resurgence in trauma memories. So it is something to be recognised as a valid treatment, an effective treatment, and the only morally justifiable treatment for opioid addiction. This is the end of Part A of Addiction Talk 4 on specific addictive substances. The next section we will be looking at is on alcohol.